The credits for getting CME today, the code was posted on the slides, and I'll also post it in the chat today. Thank you for everybody who was here for our fantastic morbidity and mortality grand rounds last week with Kyle Parikh and Amy Suhatliv. The grand rounds will recommence in 2021, so you guys will have the next 2 weeks off. I hope you enjoy it. Stay warm today, stay safe in the snow, and Jonathan Leibowitz is going to introduce our speaker for today.
I'm Jonathan Leibowitz. I'm the Fellowship Director for a Nephrology Fellowship at Robert Wood. And I have the absolute pleasure of introducing Dr. Joel Topf. Dr. Topf received his bachelor's degree in general studies at the University of Michigan in Ann Arbor. He received his MD at Wayne State in Detroit. He did a Med-Peds residency in Indiana University in Indianapolis, Indiana, and nephrology fellowship at the University of Chicago. He is a sought-after speaker. He has had multiple publications, multiple book chapters, but I think he is most well-known for being one of the very few people who can take complicated issues in nephrology and in science and distill them down into something that people can understand. He's a pioneer for teaching medical science on the internet. He's a pioneer in promoting visual abstracts, certainly within the nephrology, and does so for one of our journals, CJSON. His website is just incredible, Precious Bodily Fluids. I would recommend that when we're done here, you absolutely go there and take a look. And he's co-creator of NephJC, which is a nephrology journal club, and one of the pioneers of Nephrology Madness, or Neph Madness, which is, kind of March Madness for nephrology. It's just an incredible way, a tool for learning using, multimedia. With that, I will cede the floor to Dr. Topf, and I look forward to a wonderful grand rounds.
Dr. Leibowitz, that was a great introduction. Thanks a lot. Not a lot of chiefs of departments get it. It really is. It's nice to see that. Excellent. I'm going to be talking about the new science of contrast-associated nephropathy. Here are my conflicts of interest, a number of different advisory boards, a lot of sticky connections. In summary, many dogs, many fights, but none in today's topic. The slides for today are available at this website, sorrymyslidesaren'tdone.com, which gives you a sense of how late I'm always am in getting my slides done, that I've bought the URL, sorry, my slides aren't done, but you can pick up the slides there if you'd like. So I see this patient a few times a week, typical story, patient with CKD, diabetes, obesity, has a positive stress test, goes for a cardiac angiogram, and then in 1 week, his creatinine goes from 1.6 to 2.1 to 1.6. And this is contrast-associated nephropathy. Rarely, thank God, I also see these patients: cardiac catheterization, multiple stents, acute kidney injury, intubation, ARDS, ECMO, and in 1 week, his creatinine goes from 1.7 to 4.5 to dialysis. And these are both contrast-associated nephropathy. And I've been thinking about this topic for a while. It kind of crystallized in 2019. This was a review article, an excellent review article published in the New England Journal of Medicine. And I was reading it and I was like, contrast-associated acute kidney injury. That's not what we used to call it, right? And sure enough, I flipped back to 2006, the last time they did a review article, and we had gone from contrast-induced to contrast-associated nephropathy. And this is clearly a walk back. We're no longer saying that one thing is causing the other. We're just saying that they're kind of happening simultaneously. And that kind of opened my eyes to kind of how this topic had moved forward. The interesting thing about contrast is if you measure it in truly in milligrams or grams that are delivered to patients, it's one of the most common drugs that we use. We use, 8 million liters of the stuff every year. And, between those two review articles, there is some consensus. So the definition that we're using, and you see repeated over time, that is constantly something like this. The creatinine will rise about 0.5 milligrams per deciliter, or about 25%. Usually they'll use both those definitions within 2 to 5 days of contrast. And if you hit that, you have met the definition of contrast-induced nephropathy or contrast-associated AKI, depending on which year you're reading the review article. And this is something that I see all the time, but when you compare it to other disease definitions, it really is lacking. And I think that my favorite definition to compare it to is going to be hepatorenal syndrome. So here are the criteria for hepatorenal syndrome. So first you need a diagnosis of cirrhosis and ascites. So you need to have the right clinical setting. Okay. Secondly, you have to have acute kidney injury. That's simple. And they have a specific criteria, but regardless, you have to have acute kidney injury. Those two things make absolute sense. But look at criteria 3. You need no response to a couple of days of stopping the diuretic and giving them some volume to volume scans. And the reason here is they don't want to contaminate patients that we call hepatorenal syndrome if what they really had was pre-renal azotemia. So let's give them a volume challenge and make sure that they don't get better. That's a good addition. Absence of shock, right? So here we're saying we don't want to get patients with just typical ischemic acute tubular necrosis into our category of hepatorenal syndrome because we think this is really unique physiology. And so we're going to try to clean out those patients. So we're going to remove patients with shock, and then they kind of continue to remove other confounders, patients with nephrotoxic drugs, patients with other signs or causes of acute kidney injury, whether it's structural issues or changes on the urinalysis. And so what happens is you got a lot of patients that have liver disease and they get acute kidney injury, but only a few of them are going to be claimed as hepatorenal syndrome. And the rest of them will be kind of undifferentiated acute kidney injury in the presence of cirrhosis, but we're not going to call that hepatorenal syndrome. This is completely different than the definition with contrast-associated AKI, where we're like, hey, if they got contrast and their creatinine goes up, we're claiming them all. And so what you get is this kind of sloppy definition where you have a bunch of different patients, some of them whose AKI may be due to the contrast and others it may be due to the aminoglycoside that they're on, or it may be due to their blood pressure of 80. And it can get somewhat absurd. Like, here's a hypothetical example. Patient goes, gets a chest x-ray, they find a tumor, goes for an operation, they do a lobectomy, they get all the tumor, and a year later he's coming for a maintenance or a surveillance CT scan. His creatinine's good. He gets contrast for a CT scan. His doctor says, you're A-okay, no evidence of recurrence. And the guy gets very excited and he goes out and he celebrates. Now he celebrates a little bit too much. He doesn't remember what happens that night, but he wakes up the next morning in a bathtub full of ice, and taped to the wall is a piece of paper that says, your kidneys have been removed, seek immediate medical attention. He races to the hospital, they get an x-ray, and sure enough, both kidneys have been removed. And the guy's distraught, but the doctor's like, hey, I don't think you should be so worried, because yesterday his creatinine was 1.2, today it's 2.4, you had exposure to contrast yesterday, so I think this is contrast nephropathy, you should have an excellent prognosis, which is, clearly absurd, but this is what the definition allows you to do, and clearly, some of the patients that we're calling contrast-associated nephropathy, their AKI has nothing to do with the contrast as this patient. So there are some advantages to that definition because it makes it very easy to do retrospective and even prospective studies of the incidence. And so I'm not trying to pick on this study, but we'll just walk through kind of a typical study and what these things look like. So this was a VA study, 421 patients with GFRs less than 60, and they were looking at non-emergent CT scans with contrast. And what they found is about 6% of them hit a creatinine bump of greater than 25%, and about 3% bump their creatinine by greater than 0.5 milligrams per deciliter. And usually they will continue add both of these together or continue to measure the total incidence. And like I said, these studies are a dime a dozen. There's a million of them out there. And if you kind of take a look at the range of contrast nephropathy in patients with CKD, depending on their definitions and the populations that are used and whether it's arterial or venous contrast, you'll find a rate of somewhere between 1 and 11%. And the studies come in kind of two flavors. One will be a retrospective analysis, and the other one is this, I call it contrast on contrast violence. And this was a lot of studies done in the early part of the century of different contrast manufacturers trying to show that their contrast was less toxic than another person's contrast. And that'll be another way where we can glean what the rate of contrast nephropathy is. But it begs the question, right? If that's the rate that we're seeing a bump in this creatinine, how often does a creatinine go up without any contrast, right? Because these are all uncontrolled trials. And this study's been done. You thank the radiologist. It's a retrospective study done at an academic medical center. They looked at 32,000 patients. And what they did is they found patients that had a 10-day history with no contrast. And then they measured their creatinine. This is all retrospective. Days 0 through 4. So 5 days of measuring the creatinine. And all they're looking for is what's the change in creatinine over those days. And if we take 48 hours as the line in the sand that we usually use for contrast-associated nephropathy, and we look for a 25% increase, that comes out to 17%, right? 17% of patients are going to have a bump in their creatinine with no contrast exposure at all. And all of a sudden, you look at this 1.3 to 11%, and it becomes way less interesting when you see that, at least among inpatients, about 17% of them will cross that same line. It's just these numbers all of a sudden become less significant in my eyes. And so we kind of live in the world where anytime that we see a bump in creatinine following exposure to contrast, we call it contrast-induced nephropathy. I see it in nephrology consults all day long. But maybe it's more like a 50-50. Maybe some of them are contrast and some of them are just incidental AKI. Or maybe almost none of them are contrast and almost all of them are other causes of AKI. And the data that I've shown you so far doesn't allow you to differentiate between those three possibilities. So what we've seen is data on contrast exposure and a rate of AKI. And what we really need is have two populations, some with contrast exposure and some without contrast exposure, and then kind of compare the two to see if patients with contrast exposure have higher rates of contrast nephropathy. And I'm not sure you're familiar with this, but we call the second area a control group. Right. And the ideal way to do a controlled trial, of course, is a randomized controlled trial. And I am not going to be able to show you that. OK, but a randomized controlled trial is not the only way to do a controlled trial. So this is an example of a controlled trial that's not randomized. 6-year period, urban ER, 75,000 ER visits. And they looked at patients who had gotten a CT scan with contrast and a CT scan without contrast. Okay. First thing I want you to take a look at is just the N. Like, we like to use contrast because contrast is better. They had 7,000 patients get CT scans with contrast and less than 1,000 get CT scans without contrast, right? It's pretty unusual to go that direction because we get much more diagnostic yield when we use contrast. And then they didn't look at all these patients. They balanced them so that we had a balanced age, gender, and diabetes status. And when they did that, they found that there was actually a higher rate of contrast nephropathy, 9.6%, not significantly higher, but 9.6 versus 8.6% with no contrast. And, at first you're like, well, that's kind of absurd. I'm sure that the patients that don't get contrast look a lot different, right? There's only 900 of them versus 7,000 patients with the contrast. Clearly, patients that are at high risk for contrast nephropathy, patients with low GFRs, doctors are going to avoid using contrast in them, and that can explain the difference. And this doesn't really tell me much. And I just to show that I'm not just cherry picking. Here's a systematic review of all these controlled trials. Lots of people do them. There's 13 observation and controlled trials, 25,000 patients, nearly 26,000 patients. And when you look at the whole bit, what you find was balanced risk, the same risk whether you get contrast or not contrast. And so no signal here that getting contrast increases AKI, but all these studies suffer from the same problem I described before, is that doctors are smart and we're not going to give a nephrotoxin to people that have 2 nephrons left and a bunch of scar tissue. We're going to avoid doing that. And like when this came, one of the disadvantages or maybe advantages of maintaining a blog is you get to be able to go back and kind of see what you thought about different studies when they came out. So when this study came out in 2013, I posted a a blog post about it, and I didn't give it any traction at all. I thought this was crap. I thought, hey, if these studies are not controlled, it's going to fall into all the problems that I thought. And don't use this as a clearance to give contrast, right? Newsflash, IV contrast, still toxic. That is all. But the statisticians are pretty sophisticated, and the problem that I described before is a problem that can be addressed in a study design. And so the idea is that everybody, before they get contrast, has kind of a pre-test probability that they're going to get contrast-induced AKI or contrast-associated AKI, depending on what you want to call it. And we can predict that, right? And so we know some people are at high risk, medium risk, and low risk. And the advantage, of course, of a randomized trial is we're going to, both people that get contrast and no contrast are going to get a balanced group, and they'll have similar risk profiles to begin with. But what the problem that we've been seeing in these observational trials is that the population that gets contrast is highly populated with low-risk people, and the people that don't get contrast is going to be very populated with the high-risk populations. And so you get these distorted bubbles on both sides. And propensity matching uses that score to we're not going to look at everybody, but we're going to select a population. And so our population will have a balanced risk profile, whether they get contrast or they don't get contrast. It's pretty clever. We use propensity matching in lots of studies. And so we kind of go from a population that looks like what we see on the left to a population that what we see on the right. Very cool idea. And McDonald were the first people to do this. These are a husband and wife team at the Mayo Clinic. They used 13 variables to create their propensity score. Here's a list of what they have. And this is what the population looks before. So below the bar is patients who do not get contrast, and above the bar are people who do get contrast. And the colors represent kind of their CKD stages. So CKD1, or GFR is greater than 90, will be in green, and CKD2, GFR 60 to 90 will be in yellow, and so on. And one of the things that I think is interesting is, like, take a look at the range that the CKD 4 and 5 group look like. So all these patients have the same GFR group, yet their propensity score is still really wide, right? Because there's be some that will be old, and some will be diabetics, and and they'll be all the way over to the left, and other patients will be young and have no proteinuria, and they'll be all the way over to the right. And you can kind of get a sense of this is kind of your propensity score, even within a single tranche of GFRs. And here's what they found. And I just want to point to the last thing. There was no signal at all, even after propensity matching, that patients that got contrast had a higher risk of AKI, right? The p-values are just knocking on the door of 1.0. There's no signal here at all that this stuff is dangerous. So here the McDonald husband and wife team. She's a PhD. I think it's a statistician, but I'm not absolutely certain about that. He's a radiologist. And one of the problems or weaknesses with their research is they are funded by GE Healthcare, the manufacturer of Omnipaque and Visipake, two of the leading sellers of contrast. And I read this, and this was kind of my last bit of haven, as I said, well, I'm going to ignore this data because they're conflicted. But that doesn't last long, right? Because propensity matching is not some magic. Anybody can do it. And sure enough, this came out of Johns Hopkins, 18,000 patients. They had 7,000 CT scans with contrast and 5,000 patients without contrast, and they had nothing to disclose. And their odds ratios are all right around 1.0. No indication at all that contrast is toxic again. And then this is a really interesting study, because what's their N? Their N is everybody who was in the hospital in 2009. It's an absolutely mammoth study using a database at the Agency of Healthcare Research and Quality. 6 million patients in this study. And the risk of AKI without contrast was 5.6%, and the risk of AKI with contrast was 5.1%. That actually is a significant difference. It's, with a number needed to treat of about 200, but it actually looks like that, if you want to avoid AKI, make sure you give your patient contrast, which is absurd on its face, but, this is what their data was showing. And this actually is a study that pushed me off the ledge and really changed the way I was thinking about it. And sometimes, and I'll tell you, the reason is not so much what it said, but who said it and where it was published, right? Because the senior author on there is a guy named Glenn Chertow. And if you were to point to the leading clinical researcher in nephrology today, it would be Glenn Chertow. He's a professor at Stanford, and his name is always on the highest quality, best studies that are really driving nephrology forward. And all the data on contrast nephropathy, they're showing it not to be toxic, up to now been published in either the ER journals or in the radiology journals. And this one is in the Journal of the American Society of Nephrology. This is kind of here's our society journal with our top researcher saying, hey, this contrast, not so toxic. And again, this is 3 years later. Here's me totally reversing my position from earlier, saying, okay, I was wrong. I really was suffering from a lot of confirmation bias, right? I see patients with AKI who had gotten contrast, and every time I saw that, I said, hey, it's another case of contrast nephropathy. And you do that, I don't know, 1,000 times a year, and all of a sudden you start to think, hey, contrast must cause nephropathy, right? I see it with my own eyes. And cognitive dissonance, I just couldn't believe the previous data. It just was hard for me to get there. And this is a quote from Chertow's article. It says the incremental risk of AKI that can be attributed to radiocontrast is modest at worst, and almost certainly overestimated by patients, physicians, surgeons, radiologists, and other decision makers. I'll tell you, I think that's quite a dig to have physicians in one category and as a separate group, surgeons and radiologists. It's not very cool, but the sentiment is really important. And so, what they're really saying is that when we see a bump in creatinine following contrast, it's not due to the contrast, right? It's due to just incidental AKI. Contrast-induced nephropathy is rare. In fact, it is so rare that in dozens of retrospective controlled trials, we can't even see it. Right, and this is from the Johns Hopkins study, the second propensity controlled study that I showed. Says indeed our findings, along with those of several other retrospective studies performed in other contexts, support the notion that randomization of patients to receive intravenous contrast, once considered ethically infeasible, is very likely safe and will be necessary to fully understand the role of contrast media in precipitation of renal dysfunction. And this is the door that GE has been waiting for. They were super excited to say, okay, let's do it. Let's do our randomized controlled trial, contrast versus no contrast, and let's see if this stuff is really toxic. And one of the problems was trying to find an indication where it would be ethical to randomize patients to contrast or non-contrast. We can't just give patients the contrast for no reason. And the indication was following repair of AAAs with a stent. One of the things patients need to do is they need to have they need to be monitored every year to see if they develop a leak. And some vascular surgeons like to do that by non-contrasted CT plus an ultrasound, and other vascular surgeons, like the ones that I use, like to get a contrasted CT scan every year. And there's equipoise on which one is better. And so GE's like, this is the study, this is the indication that we're going to use, and we're going to do a randomized controlled trial here. And you can go look this up. It's on clinicaltrials.gov, endovascular aneurysm repair, monitor for leaks. And, but I don't want you to get too excited because less than a year after they started, they shut this thing down. They couldn't recruit patients. I think they wanted 1,200 patients, and after a year of recruiting, they could only get 12, and they were never going to be able to complete this trial. And the reason was that everybody in the contrast nephropathy space that was keeping up with the literature had equipoise. They said, yeah, the data looks like this stuff is not nearly as dangerous as we thought. But general nephrologists and general internists didn't buy that, wouldn't enroll their patients, and just it couldn't move forward. And so we're kind of left in this position that retrospective propensity matched trials, really the highest quality evidence we are ever going to get, cannot detect any excess AKI following contrast. And when we tried to get higher quality data, we couldn't do it. We just couldn't enroll the patients. And I'm not saying that this is a closed story, right? There's probably some residual confounding. Like you just look at the Chertow study showing a lower risk of AKI with contrast. I mean, I don't believe that contrast is beneficial to the kidneys. I think that is evidence that there is residual confounding. We have not, our propensity scoring is not perfect. So that's one source of error. And the other one is everything I've been showing you so far has been on venous contrast. And that's one side of the coin, but the other side of the coin is going to be a lot of arterial contrast that we use when we do angiograms of the brain and we do angiograms of the heart. And before we move on to arterial contrast, I do want to hit one other aspect of contrast-associated nephropathy. If you've read any articles about this, this is one of the high points that they will talk about, is that contrast nephropathy predicts mortality. And the studies, there's a number of studies that show it, but there's one typical one. But essentially what they do is they take a bunch of patients that all got exposed to contrast, they divide them up whether they've had contrast nephropathy or not, and then they look at their hazard ratio for 30-day mortality and their hazard ratio for overall mortality. And contrast nephropathy does seem to be a really, really important marker there with really, really high consequences for people who get contrast nephropathy. And the implication here is that, patients get sick. Because they're sick, they get contrast. And because they're contrast, they get acute kidney injury. And because they get acute kidney injury, they die. Right? That's the chain of logic that they're trying to sell when they talk about this. But consistent with the data could also be they're sick, and because they're sick, they get contrast. And because they're sick, they get AKI. And because they're sick, they die. And it's not one following the other, that these are all kind of concurrent. And the way that you would test this is if you could prevent the kidney disease. If you also prevented the mortality, then you have the top situation. But if you prevent the kidney disease and they still die, you have the bottom situation. So one of the kind of the logic says, oh, the contrast-associated AKI is associated with mortality. And risk factors for contrast-associated nephropathy include age, CKD status, and diabetes. And the problem with those risk factors for contrast-associated nephropathy is they are also risk factors for mortality. And maybe what's going on is maybe the contrast-associated nephropathy is really just a marker and helps you identify patients that are of high age, low GFR, and high diabetes status, and that you don't have the AKI actually causing the problem. And one study that tried to untie this knot is the PRESERVE trial. We're going to come back and talk about the PRESERVE trial. Probably it's the highest quality data that we have on this whole issue. And one of the things that they got right is well, they looked at contrast, but instead of looking at your typical definition of contrast-associated nephropathy, this quick, short bump in creatinine, they actually looked at, let's go back and see how many patients die or end up on dialysis or have a persistent increase in creatinine of 50%. And this is kind of their primary data. They enrolled 4,400 patients. They had about 10% of them develop contrast-associated AKI. Now, I want to emphasize the contrast-associated AKI was not their outcome here. Their composite outcome is the bottom blue, composite outcome of 191. That's the ultimate outcome they're looking at. But what I want to point out with, okay, so the 429 that had contrast-associated nephropathy, the vast majority of them, 376, did not reach that composite, right? Only 53 who developed contrast-associated nephropathy developed that composite outcome. In fact, there were nearly 3 times more patients who didn't develop contrast-associated nephropathy developed that composite outcome. That is of patient significance than the patients that had contrast-associated nephropathy. Kind of further evidence that this definition is really not very important. And then the point of the trial was to try to see if the contrast-associated nephropathy was a marker or a cause of that composite outcome. And I read the article a number of times, and I did not understand the statistics. I love understanding statistics. I could not figure this one out. I don't know if it was a poorly written article or a poorly, my intelligence was not enough. I just call it a black box. But their conclusions, and I don't know if they're reliable, just said that contrast-associated AKI was a marker and not a cause of the composite outcome. And you can kind of see that when you see that a lot of the patients, in fact, 3 times as many patients develop that composite outcome without contrast-associated nephropathy. That's probably where that data comes from. But again, I could not understand it. This is also from the PRESERVE trial, and I think this is some of the most compelling data. So I want to walk through this. When we look at kidney function, we always use creatinine, and creatinine is a functional marker. Fields like cardiology and hepatology, they've moved on to biomarkers. They actually look at damage to the actual cells with troponins, and in hepatology, when they look at SGOT and SGPT, or AST and ALT, we're looking at actually evidence of damage from the cells. And we don't use those in nephrology clinically, but we do use them experimentally. There's a number of them. Here's 6 kind of typical biomarkers in nephrology research. And one of the interesting things is that we have different markers. They actually mark different things. And some of them are inflammatory, and some of them are repair markers, and some of them really target different aspects of the kidney anatomically. And so a sub-component of the PRESERVE trial, there was 922 people, so about 25% of the PRESERVE trial actually had these biomarkers checked. And again, most of the patients, 90% of the patients didn't develop contrast-associated nephropathy, but about 10% of them did, a little bit less in this study, 73 out of 922. And so here are these biomarkers, and these biomarkers are found in the urine. Some people do them in serum. This is a urine test. And what you have on the left in the light blue are the patients who did not have AKI. And in the right is the patients who did have AKI. And what you want to see is that the patients who have AKI, that number should be much, much higher. And partially, well, the first thing I want you to say is, Topf, you're terrible at showing graphs. Why did you make them so small? And what I want to say is, first of all, there's no difference between these. There was no signal that the biomarkers went up when you had acute kidney injury. But what I really want to show is what some other diseases do. So the green, whether it's light or dark, that's just patients who run a marathon. Now again, the light green, they run a marathon and they don't have any AKI. The dark green, they run a marathon and they develop AKI. But look at how much higher the biomarkers are just running a marathon, whether they develop AKI or not. Right? There's a ton of stress on the kidneys running a marathon, way higher than getting contrast. And the red one is bypass surgery. And again, here you see clear that if you get AKI following bypass surgery, your biomarkers go up dramatically. But even if you don't develop AKI getting bypass surgery, your markers are quite a bit higher than what you see in patients who get administered contrast, whether they develop AKI or not. Right? The point of this study is that we don't use a renal troponin, but if we did, it would be negative every time with this contrast-associated nephropathy. It's not, there's no signal that it causes problems. There's no signal at all. So this is kind of where we are. We have this walk back in the review article from contrast-induced to this associated AKI. And the reason for that is when we just look at the background rate of AKI, it's at least as high as there is for contrast nephropathy. When we do propensity matching, we can't find any signal at all of increased AKI. And when we even do biomarker studies, there's no there. So all of this data has been on venous contrast. I promised you some information on arterial contrast, and let's get into it. And I want to start with one of the big advances in interventional cardiology is moving from ephemeral access to radial access. And, like any kind of big changes in established fields, it was kind of some young rebels that started doing this, and there was a lot of pushback from conventional cardiologists. And, one of the arguments early on is, oh, these radial people, they show great outcomes, but they only choose the easiest cases. They don't do the complex cases. They don't do the difficult cases. They get the stent in, but it's not as good. They don't get as good a durability. They don't get as good of outcomes, even if the early outcomes are positive. And the radial people said, okay, well, let's put it to the test. And there was actually a randomized controlled trial. They took patients with ST elevation MIs. They randomized them to either femoral or radial approach, and about 4,000 in each. And here's their primary outcome, which was 1 year outcomes for major adverse cardiac events. And there was no difference. They barely missed a significant p-value, actually showing an advantage for radial, just barely missed it. But certainly all they wanted to show was no difference. And they clearly crossed that bar, no difference at all, possibly an advantage for the radial approach. But what I think I'm most interested in, and what a lot of the proponents of it said, we get the same outcomes with a significantly less, right? A number needed to treat of 50 less for adverse events. That's pretty impressive. But interesting, one of the adverse events that went down pretty significantly was acute kidney injury. And so this was kind of the breakdown of their acute kidney injury. And so the absolute reduction was 13% in acute kidney injury. But if you look at KDIGO stage 3, this is the advanced acute kidney injury. This is the people that have a tripling of their serum creatinine. They had a 40% reduction of that. So the AKI you really care about was dramatically reduced. And even more impressive, but not significant, the only significance here was the need for dialysis. 6 patients with radial approach, 14 with femoral. So again, 13% reduction in overall contrast nephropathy, but the serious adverse events seem to be really reduced. There seemed to be a real difference here. And if you read the editorials about this, they said that it's probably due to less bleeding causing hemodynamic instability. But one thing I wonder about, I wonder if we could be seeing that this cholesterol emboli syndrome, generally considered a pretty rare complication, may be more important than that. So what happens here is you've got a cholesterol plaque, and as you do a procedure, you de-roof the plaque by disrupting it, and then it spills out this cholesterol crystals, and they land in the kidney, and they get dissolved when we prepare a biopsy, but they do leave these ghost-like clefts in the kidney, and they cause pretty intense inflammatory reactions, and they cause acute kidney injury. And if you look, these emboli, of course, don't just go to the kidney, they go anywhere downstream. And the classic story is this purple toes that you'll see in patients with catastrophic cholesterol emboli syndrome. And when you do prospective analysis, when you really look for these purple toes and the consequences of that, you'll find this happening in about 1% of cardiac caths. But there was a couple of series of autopsies where they looked at patients who had died following aortic surgery or aortography, and they found a much, much higher rate of evidence of cholesterol emboli in patients that probably didn't clinically see this. It's just when you do the pathology. And I wonder if this is what's going on, that the femoral approach puts the kidneys at risk of cholesterol emboli in a way that the radial approach does not. And that's why we're actually, not only we're cutting down this evidence of AKI following contrast, but we're really cutting down on the most serious cases, the ones that cause dialysis or tripling the serum creatinine. Again, it's very speculative, but it's something that I'm curious about. One of the other things that's happening is the cardiologists are using less and less contrast. Remember the story I told you at the beginning about this patient who ended up on ECMO and finally on dialysis following contrast, a cardiac cath. One of the interesting things was I brought up the consult, and I said, "So how much contrast did he get?" And the cardiologist fellow said, "None. He got no contrast." And I just figured I misunderstood him. Next day I was talking to the attendant. It's like, "Well, what do you mean? The fellow was telling me he got no contrast." And they're like, "Oh yeah, this is a new thing we're doing. We're doing zero contrast cardiac caths." And there's actually a series on this. This is kind of the new frontier. This is a series of 31 patients, and this was not no contrast, but incredibly low doses. Right, their goal always is to get less contrast than their GFR number. So their average GFR in this study was 16, and they used on average only 13 mils of contrast, and the result of acute kidney injury was 0. And really, really impressive results. There's a number of techniques that allow to do this, all very clever use to avoid using contrast. Usually it does require a scout procedure. So they'll do a traditional cardiac angiogram a month before to define the anatomy. And then they have a bunch of tricks to allow them to use minimal contrast when they actually go to do the intervention. And this advance in the technology of cardiac caths is not isolated. There's been tons of advances, right? So I think one of the reasons we're seeing such a low rate of contrast nephropathy or not being able to really detect it is because of all of these advances. We've moved from high-osmolar contrast agents in the early 90s to low-osmolar contrast agents or iso-osmolar contrast agents. We now use biplanar angiography, so we get two views of the vessel with a single shot of contrast. We don't do ventriculograms anymore. We use intravascular ultrasound to minimize contrast volume. And the CT scanners allow us to use lower doses of contrast because of just better technology in the CT scanners. And, one of the things, I've been giving this lecture for a bit. When I first started doing this, I got a lot of pushback. But last, I want to say March, it may have been April, the American College of Radiology and the National Kidney Foundation put out a joint statement. And essentially, it was a lot of what I'm talking about here, saying that the risk of acute kidney injury developing in patients with reduced kidney function following exposure to intravenous iodinated contrast has been overstated. And trying to kind of walk back everything we've been teaching people for a long time, because it's probably, we've gone too far. And I get, one of the sources of pushback I get is, well, it's a nice lecture, Topf, but, it's better to be safe than sorry. I just want to avoid contrast if I possibly can. And I just want to caution you against something called renalism. And renalism is the underutilization of diagnostic and therapeutic interventions in patients with kidney disease out of concern that they are more likely to do harm in this patient group. And the idea of this word is to make it sound like racism or sexism. And, and you can see renalism everywhere. So this is just a kind of a typical nomogram of the rates of people using contrast based on serum creatinine. And you can see that in general, they'll use contrast all the way up to a creatinine of 1.4. But as soon as there's a little H next to that creatinine in the EHR, using contrast falls dramatically. And there's no reason to think that the diagnostic yield of contrast in a patient with a creatinine of 2.5 is any different than it is in a patient with a creatinine of 1.5, but we're using a lot less contrast. And I think the end result is those patients with those higher creatinines are getting worse data back. And, here's there's a lot of studies that have looked at this, but, the big picture is that anytime you compare rates of PCI with patients with CKD or no CKD, you find that patients with CKD get less PCI, right? It's just, we're not doing the cardiac interventions, indicated or not, in patients with CKD. And this lecture used to have a big section on renalism going deep into some of the data about this, but I've kind of backed off since the ischemia CKD trial, which I thought was super interesting. So this came out last spring, and the idea behind ischemia, there was a big ischemia trial, which was answering that age-old question: patients with stable coronary disease, do they get a benefit from getting stents? And there was no survival benefit, and there's surprisingly little, quality of life benefit, and surprisingly little angina benefit. It's amazing how good medical therapy is alone without a cardiac intervention. But there was a side trial on that looked at patients with advanced CKD. And this is like manna for heaven for us, because we get so few cardiology studies that enroll patients with low GFRs. So this was 800 patients with very, very low GFRs. I'll show you some data on that. But the bottom line picture was there was no difference in their angina scores. There was no difference in their survival. It just didn't help to do an interventional procedure. So this is a medium GFR of 23. So these are patients deep into CKD stage 4, invasive strategy versus an optimal strategy. There was a significant stroke risk with an invasive strategy that they were unable to explain in the discussion section. It was not around the procedure. This is not a peri-procedure stroke. So I don't know if it was the antiplatelet agents that they got put on or what have you. There was a slight increase in the amount of dialysis that started with the invasive strategy. But I mean, I want to point out that, 29 of the patients who did not receive contrast started dialysis. And so, that 36 looks bad, but it's not nearly as bad when you look at the rate of dialysis when you don't do this. Kind of starting to wrap up, I want to kind of change the way you look at contrast nephropathy. And I want to compare it to vancomycin nephrotoxicity. And so first of all, does this exist? Yeah, vancomycin nephrotoxicity is not a myth. It really does exist. Contrast nephrotoxicity does exist, maybe, but if it does exist, it exists below the limits of detection. We can't see it when we do our best controlled trials. Do we have alternatives? Yeah, we have tons of alternatives for vancomycin toxicity, but we don't typically use them. Contrast, this is the data you can only get from contrast. We don't really have good alternatives. How much do we worry about vancomycin nephrotoxicity? I don't hear anybody worry about that. They start the vancomycin and if the patient develops AKI, they call me later. No one ever thinks about it prospectively, but contrast, no one will give them a CT scan at all until they do everything to prevent that or decrease the risk of it. And that results in a delay of care. And again, this comparison comes from an ER doc, and they're very much concerned about the flow and speed and getting patients through flow. So speed of care is super important to them, and we delay a lot of it because of this concern about contrast nephropathy. So this is the algorithm that I use, algorithm for avoiding contrast nephropathy from CT scans. You got a critically ill patient who needs a CT scan. First question, what is the glomerular filtration rate? Second question, actually forget it, I don't really care. Could IV contrast help improve diagnostic imaging and provide better therapy? If the answer is yes, use the contrast. Do you need contrast? Yes, use the contrast. Definitely the way to go here. But sometimes we have the luxury of time, and can we do anything to lower the risk for anticipated contrast exposure? I just kind of want to walk through the history of this kind of studies. And I want to start with everything that we think we know about contrast nephropathy comes from a time when we believe that receiving contrast causes the AKI. And I think it results in this weird thing where you get this list of the risk factors. And you can find this in any review article. Here's your risk factors for causing contrast nephropathy. And then I want you to take a look, well, what are the risk factors for causing just AKI in general? They're entirely identical except for the high contrast dose, right? And so I'm not sure if none of these things seem to be specific for preventing contrast nephropathy. And these are just kind of general guidelines that we use to reduce AKI. The first important trial in the reduction of risk of contrast nephropathy is the Solomon trial. It's a tiny trial, 75 patients. This allows you to get into the New England Journal of Medicine in the mid-90s. And what they did is there was a theory that if you used mannitol, you would flush the contrast through the kidney very quickly and prevent contrast nephropathy. And then there was another thought that if you use furosemide, you would decrease oxygen consumption by the kidney, and that would preserve it and prevent it from toxicity. And the result was that both of those tended to be toxic, and that the winner was half normal saline, mainly because it was the only one that didn't cause harm, right? And so these were theories about how we could prevent contrast nephropathy. They were wrong. And so the winner was half normal saline, and that was the standard of care. When I started my career, a few years later, Mueller did a trial of half normal versus normal saline, and they showed a significant reduction in contrast nephropathy. And so we then transitioned from half normal to normal saline. And then there are two trials that compared IV hydration to nothing. So I love this. This is the AMACING trial, the AMACING trial. And this is taken, I want you to carefully look. This is GFRs 30 to 59, elective contrast procedures, either giving no prep or normal saline, and there was no difference in the risk of contrast nephropathy. This is a big win. This is a question that comes up all the time. Can we give contrast? What do we need to do? And the reality is if they have GFR of 30 to 59, you don't need to do anything, right? GFR's 47.5, contrast doses were significant. They had a third of their patients with diabetes, which is reasonable. Their saline dose was reasonable. They weren't underdosing them. And a third of the patients were getting intra-arterial contrast, so cardiac caths or angiograms, higher risk procedures. And there was no difference that the saline did not help prevent it in this population. Good to know. It's interesting. People talk about that it's better safe to be sorry. I still give saline. Well, they had 8 episodes of contrast nephropathy without IV saline, and they had 18 complications due to IV saline. And so it's not like normal saline, 1.6 liters is innocuous. Some patients really can't tolerate that. They did have some interesting complications. I don't know how normal saline causes arrhythmia, but they blamed 4 cases of arrhythmia on that. Kind of a reproducibility study. This is the KOMPAS trial. Nothing versus a bicarb infusion, pretty small volume, no significant difference in contrast nephropathy, though there were higher rates in the nothing group. This is just an example of reproducibility. Again, the breakdown of the patients, CKD stage 3A and 3B, 40% diabetes. Their hydration was pretty minimal, only 250 cc's of bicarb. That may be part of the problem here. And it was all IV contrast, no arterial contrast. And then isotonic bicarb and N-acetyl cysteine. I hope we've put these to rest. It's a tale of 2 placebos. So this is the Merton trial on IV bicarb, 60 patients in a group. This gets published in JAMA, dramatic reduction in contrast nephropathy. And I'd say the winner here are the editors because it resulted in a little cottage industry of trials and meta-analysis about bicarb. I love in 2010, we reached what I call the Cochrane inversion, where we actually had more meta-analysis than trials. But the other placebo that I like to talk about is N-acetylcysteine. This is the Temple study published in New England Journal of Medicine, only 40 patients per arm. Again, dramatic reduction in contrast nephropathy, but total chaos in that a million trials were generated following this. And there's a lot of meta-analysis. This is the meta-analysis that I think generally is the highest quality one. And one of the things that they looked at 22 studies and they said it had unacceptable heterogeneity and they were unable to make a final conclusion. This is how the data is usually reported, but they did something interesting. They did report change in creatinine with NAC versus change in creatinine in control, and they found the source of the heterogeneity was here's group 1 and here's group 2. And in the meta-analysis, they couldn't figure out what the difference between these 2 groups were. But they said, there's something going on here. We have 2 different groups, and the group 2 shows a real dramatic effect of protection from N-acetylcysteine that we don't see in group 1. And later, people recognize, it's actually how they measured the creatinine. And there are a couple of different techniques for measuring the creatinine, and the enzymatic technique was actually thrown off by the N-acetylcysteine. And that's the source of all this. This whole thing was a pipe dream and an illusion. Talked about the PRESERVE trial earlier. This is what the point of the trial was. It was to finally put to rest sodium bicarbonate and N-acetylcysteine. It was a 2x2 factorial trial. We talked about the endpoint being really strong, patient-oriented outcome of death, dialysis, or a 50% increase in creatinine at 90 days. And there was no signal whatsoever. Neither of these drugs work. These don't protect you from contrast nephropathy. I do want to point out the size of this trial. Each one of these arms had 1,200 patients in it. And compare this to the 80 patients total in the Temple trial and the 120 patients total in the Merton trial. This is a plea to the editors of the NEJM and the editors of JAMA that even if the study looks exciting, you guys are way too high profile. These studies literally changed the standard of care overnight, and they were totally placebos. And it took us a decade or two to dislodge these standards of care that should never have been put into place. And it took a massive study with 1,200 patients per arm to do it. So conclusion, the vast majority of contrast-induced nephropathy or contrast-associated AKI is modest increases in creatinine of no clinical significance. The reason we believe it is common, it's a non-specific definition leading to frequent confirmation bias. So we need to stop harming our patients by denying them the diagnostic studies they need. Thank you. I'll be happy to take questions.
That was fantastic. Thank you. I really liked your discussion of cognitive biases, and in all honesty and being fully guilty of it, I think I probably reached out to you with my own sort of confirmation bias, thinking that you may come in with this sort of presentation because I had this view that maybe we're thinking about contrast-associated nephropathy in the wrong way. So I'm guilty of it myself. And I think you talk about, our avoidance of contrast in patients who have risk factors for contrast-associated nephropathy, as this is kind of like an omission bias, another kind of bias that we kind of sometimes fall into. And you talked a little bit about some of the physiologic changes that could theoretically be causing this. And so I'm wondering if you can kind of use some of your discussion of confirmation bias is our finding of these physiologic changes, vasodilatory changes in the tubule, change in urine viscosity, leading to an ATM-like picture. Is that confirmation bias? Are we looking for a cause of something that we thought was there? Or was there a perception that there was a contrast issue and therefore looked for clinical changes?
Yeah, I mean, I think that's exactly right. Like first of all, I think there really was toxicity when we first started using contrast agents in the early 90s. I think those agents were very toxic, and we have moved long past that. And I think that part of the reason that we can't detect it anymore is we've made advances in this field and it's no longer an issue. But once you had that bias and once you were oriented to trying to prevent it, there was a lot of energy in trying to prevent this. And one of the problems, you try to take a look at, animal models for contrast nephropathy, they're not there, right? You can't cause a rat to get contrast nephropathy unless you load them up with NSAIDs and dehydrate them in the first place. And who knows what you're actually looking at once you've done that. And so, that probably should have been a signal that maybe this is not as serious as we thought. There now is a molecular mechanism that's generally accepted that causes contrast nephropathy. I don't cover it here because even the people that publish it say, yeah, we think this is how they cause the toxicity, but we think it's incredibly rare. We don't think this is actually what most people see. 99% of the time that you're seeing contrast nephropathy on the consult floor, what you have is incidental AKI who got within the 2 to 5 days of getting contrast. The problem is, and I think really one of the dangers is that as nephrologists, if you don't accept this, you go and you get the consult and you say, oh, they got contrast, that's all we got, and you don't dig deeper, right? You can get this, you can too quickly settle on a diagnosis.
Right. Thanks. So we have a question, and then I'll open it up if anybody wants to unmute themselves and ask questions. But Laura Willett was asking, in follow-up to your discussion about arterial versus venous contrast, there was a randomized controlled trial in radiology last year by Schonenberger that looked at CT coronary angio venous versus coronary angio arterial, showing higher AKI with the direct angio. And the question is, do you think that this is due to direct aortic injury, or is it due to the contrast?
Well, I mean, I don't think it's due to the contrast. I could be due to aortic injury. It could be due to bleeding. Like anytime going into the arterial is going to be more dangerous than going into the venous. Kidneys are fragile. I think there's a number of explanations there. I'm not trying to argue that doing angiograms is safe. I think doing angiograms is associated with acute kidney injury. I just don't believe it's due to the contrast. And I would add that decision to then avoid the angiogram if the patient, if it's indicated the patient may be causing more harm than good. Sorry about that, Dr. Liebowitz.
Hi. So just a couple of things. The first is that even as a renal fellow, we knew that the natural history of this, whatever it was quite good. People might have a little bump in their creatinine, but then over time, most people just resolved. So when you're looking at trials like PRESERVE, and you're looking at multiple, different interventions to prevent something that probably won't happen, it becomes harder to find, a conclusion that, actually makes sense. Like, if you're going to intervene on something that's going to generally have a good outcome, it becomes much harder to study, assuming that there is anything there at all. The question I had though is more if you have multiple hits or multiple high doses of contrast, sort of how do you look at that and how do you handle it? If you have someone who already has, AKI from a number of different things in the ICU, do you then give them contrast knowing that, maybe that would be another factor? I mean, generally, I think I use your rule of thumb that, if they need the study, they need the study, and then we'll deal with whatever consequences there are because, there are no guarantees in the ICU anyway. But if you have these patients that are coming in for, evaluation for kidney transplant, their EGFR is, 15 to 20 and they need a cath. Do you go ahead with the cath? Do you wait on the cath? I mean, that becomes more of a dicey situation.
Yeah, I mean, there's definitely a signal in the ischemia CKD that patients that got cath ended up on dialysis, right? That's definitely something that happens. And I'm not sure if I care if it was the contrast that was directly toxic or the bleeding complication that happened after they went into the arterial line or what it was or it was cholesterol emboli syndrome. I don't think it much matters. There is a risk of patients ending up on dialysis. I think you need to be cautious in that circumstance. I agree that it's a dicey situation.
We're getting up just past the top of the hour. If there's any other questions anybody has, you can go ahead and unmute yourself.
Just quickly, do you use any contrast prophylaxis at all? Do you give normal saline before, or you just let it go?
So I don't in CKD3, and I use normal saline in CKD stage 4 and 5.
It's interesting because most of the consults are in CKD 2 and 3.
That's
which
right.
I find, what do you do?
I tell them to go ahead and get the contrast. Don't worry about it. You're going to be fine. That's right.
All right. Well, wonderful. Dr. Topf, that was fantastic, as I knew it would be. Educational, interesting, enjoyable, and some laughs in there. So thank you so much for being with us today. Happy holidays. Stay safe.
Thank you very much. Take care.
See everybody in 2021.